So I will be talking about the pharmacological management of neuropathic cancer pain. Uh, if you see, there is an extensive literature about neuropathic pain rather than neuropathic cancer pain or a cancer neuropathic pain. If you see that, and whatever guidelines which have come is mainly about the neuropathic pain. And if you see in my few slides, you will see that it will be mainly about the diabetic neuropathy or a post-herpetic neuralgia. Rarely there will be a literature which will be highlighting something called as a chemotherapy-induced peripheral neuropathy or a cancer neuropathic pain. And I think it is our responsibility as palliative physicians that we should delve into this more research, and we should come out with some very valid evidence in the near future. So coming to that, my SLOs will be about understanding the pathophysiology. I am not going into that. That's why I highlighted it red. We will be talking about the guideline-based drug choices, apply the principles of drug selections. Then we will recognize when to combine the agents and how to adapt to special populations, especially most of the patients who come to the palliative care physicians, they have many comorbidities. We need to really know that, and we will appraise the evidence and guidelines. But I think due to shortage of the times, I am not going into that point. So I will just stop till the adapt and management for special populations. So it's a very simple thing about neuropathic pain. It is just a damage to the nerve. Okay, so the damage can be physical, or the damage can be more than I can say a physical damage. We will come to that. And it is basically by the tumor or by the chemotherapy or a surgery or the radiation when we talk about something called as a neuropathic pain in cancer or cancer neuropathic pain. Alright, and it is almost present in almost 40 to 60% of the patients. And the characteristics are similar as what the neuropathic pain patients do have. But at the same time, you have to see to it that in cancer patients, I will come to that in my next studies, it is a mixed type of component. You will rarely get to see a very pure neuropathic pain component in this group of patients because the tumor itself is there, which has an inflammatory component. So there will be a lot of nociception in this group of patients. So that's why it is always and almost 40 to 60% of times it is a mixed pain. And it is often resistant to opioids alone. So we always need to add some adjuvant medications, as Dr. Nandini Mallas has already highlighted. Yes, we start the patients with morphine or other opioids, but at the same time we have to see to it that whether the adjuvants really help them. So the adjuvants, we will come to that, what are the different adjuvants. So we did one study, and my student has done one of her thesis. This is my thesis of one of my student, and we had seen, there is a huge literature gap to say what exactly is the cancer neuropathic pain, because they had just gone with the symptoms of burning, shooting, stabbing, right? Alright, if you see even a post-operative pain, there will be a burning component, there will be a shooting component. So we can't categorize this as a neuropathic pain, right? So there has to be certain criteria by which we really have to categorize what exactly is a neuropathic pain. So we saw that huge literature gap which is existing, and we thought how to get down onto that gap. And so we have used a IISP diagnostic criteria to really find out what exactly is a neuropathic pain, my students. And we found almost 46% of the patients do suffer from neuropathic pain when we have used this criteria. And the commonest group of cancer patients who have this pain is the head and neck cancers. Okay, and there is something called as, you will frequently encounter this terminology called as CIPN when you practice your pain as well as palliative medicine. And it is called as CIPN, that is a chemotherapy induced peripheral neuropathy, and it is nothing but because of the agents which are used to cure or to control the cancer. And the commonest one is the paclitaxel, which causes we have also found that it has a significant contribution, and it was statistically significant in our group of patients. So coming to the definition, so what exactly it is pain arising as a direct consequence of a lesion or a disease which affects somatosensory system. We have to be very clear. And what I see and hear and do in my networking, and when I meet different group of people know they are working, people are working, but they are really not very clear about the concepts. So this is very, very important to understand. I have highlighted this in bold. It is somatosensory system. It is not autonomic system, because if you look back, there is something called as a CRPS, which also has an autonomic component, and there is a huge dilemma whether to include that or categorize this into neuropathic pain or not. So that's why you have to be very clear. It is purely somatosensory system. I can see very young faces over here, so that's why I'm stressing on this point. Neuropathic pain is purely somatosensory system as far as the recent definition is considered. Okay. So coming to the guideline based drug choices. So recently in just 2025, the Lancet Neurology has come up, and you can see this group of people who are a part of the neuropathic special interest group. They work very really hard, and they, I think every 5 years they come up with these guidelines, and in 2025, just August 2025, Lancet Neurology, they came up with these guidelines. And if you see, they have categorized broadly into the first line recommendations, second line recommendations, and there is something called as a third line recommendations. We will go to that also. Okay, so what are they saying that? Now, if you see, these are the group of drugs like carbamazepine. Okay, the carbamazepine is the commonest drug which we use for trigeminal neuralgia, right? It's the first drug of choice whenever the patient comes with TG, and we just start the patient on carbamazepine, 100 milligrams, 200 milligrams, whatever may be the dose. But if you see, there is an inconclusive evidence about the use of carbamazepine. On top of that, there are many major, I can say, life-taking side effects when we use carbamazepine. So you have to be very careful when you are using that. Okay, even the NMDA receptors, especially the ketamine, which we use, and we are very fond as an anesthesiologist. I have a background of anesthesia. We just use ketamine. Are ketamine laga do patient, we will see that. Okay, so even that has a very inconclusive evidence. And if you see the cannabis, the new boy in our pain medicine practice as well as palliative medicine practice, they are strictly against it about the use cannabis. Okay. This is what is the recent recommendations I am talking about, but many people who are practicing over here, they can say that, oh, I have been using cannabis for many years. I can say many years means 3 to 5 years, I can say that, and they will say, I am very happy with that. Yes, well enough. We are not contradicting you, but I am just talking about the literature over here. Alright, so these are the drugs which have a strong recommendations, that is a alpha-2 delta ligands, that is a gabapentin and pregabalin, which we use very commonly in our group of patients. And I can say many other colleagues, different specialty, I can say especially the orthopedicians, they just use left and right in all group of their patients. And now I have been seeing, because when I was practicing my anesthesia, I had been seen even the anesthesiologists using gabapentin or pregabalin in acute post-operative pain also. We will come to that later on. That's the first line of medication. Second is SNRIs, that is a duloxetine, which is a very commonly and widely used medication in our practice, I can say that. And then tricyclic antidepressants, age-old medications, I can say, and that's my special drug I use to my all group of patients. Other than this, I use it because it is an anxiolytic. So to calm the patients because they are suffering from cancer, that anxiety is taken care of, that not only as a pain medication I use it. Alright, so weak recommendations, it's a lidocaine 5% patch which is available, I think not very freely in India, but at bits and pieces in some parts of our country it is available. I don't know about Bangalore, but in Mumbai it is available, 5% lidocaine patch. Capsaicin, it is not available. It had come into the market previously, but I don't know, somehow it didn't pick up well. I really don't know why it didn't pick up then, so but it's not available nowadays. And the weak recommendation is for the opioids also. Now, I would like to underline the fact saying that we use opioids in most of our patients who are suffering from this group of pain. Why? Because one thing is about the intensity of the pain, because we really need to take care of the intensity as well as the pathophysiology. Okay, so for controlling the intensity, we target the patients with opioids, and for looking at the pathophysiology, we target the patients with alpha-2 delta ligand blockers. So that is how we balance our medications and we try to take care of this patients. Not only with medications, there are many other things which Dr. Nandini Wallat has spoken very well, and this is what we really reflect upon ourselves, not just giving medications, but there are many other things. We really need to sit and talk with the patients and ask if he's taking, how much is he taking, why is he taking, what time is he taking. That is also very, very important. Even we had seen the patients, you tell them to take it 6 p.m., they will take it at 9 p.m. So these things do happen, and there is a long gap which happens, and as for the pharmacokinetics they may not be effective. So that's why it is very, very important. Right. So coming to the gabapentins, I'm not going into the details, just an overview. They act on the voltage gated calcium channels and they modulate the alpha 2 delta protein. So that's why they are called as alpha 2 delta channel blockers. But actually the channel is the calcium channel blocker. We have to remember that. Okay. So there are many positive randomized control trials, and you might be wondering which drug to use. So there is a lot of dilemma in our practitioners, like whether I should use pregabalin or whether I should use gabapentin. There are many factors which drug to be used for what. Okay. Though here I am saying that gabapentin is for neuropathic cancer pain, pregabalin, you will see there is no mention of neuropathic cancer pain. That doesn't mean that it can't be used for that. It can be used for that, but there are various things when we are using it. So now the most important thing is the cost factor. If you see, pregabalin is a bit expensive compared to gabapentin. That is the one of the thing which we see. I work in a tertiary cancer setup, in a government setup where the patients are poor. So I usually try to see to it that I can give the cheapest medication to this group of patients. Again, it depends what group of patients are coming to. It is not, there is nothing wrong, there is nothing right. You have to just weigh the things which you use and which is right for your patient according to the patient who is coming to you. Alright, so another thing why I consider gabapentin when I would like to use is that because gabapentin is also available in 100 milligrams formulation. So I can titrate this medication very well, because if you see pregabalin, it is not available as a 25 milligram formulation currently in India. So titration becomes a bit difficult. So that's why I take gabapentin 100 milligrams in a lower dose, because most of the patients are also on other medications. We have to see that, because they might have visited a psychologist before he coming to you, or a psychiatrist before he has come to you, and you might be on those medications already. Or if you take a history of these patients, they might be already on certain sleeping pills. So all these things make a major thing. Plus we are also adding certain group of pain medications which also cause sedation. So there should not be a combined sedative effect on this group of patients. So that's why we start with a low dose. So that's why it becomes, so my drug of choice always is gabapentin. I start because I have a good titration with this group of medicine rather than pregabalin. You are not wrong if you are starting pregabalin, but again you have to see to it that whenever you are starting with both these drugs, I'm not going into the pharmacokinetics, we can discuss that during our breakfast. Gabapentin or pregabalin, I usually start this as a HS dose in the night time. And why we start it in the night time? Because it causes dizziness or giddiness in this group of patients. That's why most of the patients who come to us are working or doing some other activities. So they should not feel that giddiness when they are taking this daytime medication. So that's why we give it. Another aspect, a practical tip which I would like to highlight is that we usually, HS is a very broad term. Okay, so for me HS is, I sleep at 11. So my HS is 11. For some persons the HS is at 9 p.m. So it varies. So rather than saying HS, I usually give a time to this patient. So you have to be very specific when you are prescribing these medications, and I always tell them that you take it at 8 p.m. The other reason why I tell them to 8 p.m. is that because when you take it at late night, it becomes difficult for you to wake up in the morning. So that's why I prepone it a bit at 8 p.m. so that they can wake up easily. So all these things are important when you are prescribing this group of medication, that is either pregabalin or gabapentin. Okay, so this is how I usually start it. Though I have stated 25 milligrams, pregabalin is not available in our country as 25 milligrams preparation. But where we used to work in Singapore, there was preparation available 25 milligrams. We used to start that way. But gabapentin we usually started at 100 milligrams. And what we use it that either if you are starting it at 100 milligrams, you have that liberty to increase it every day. Now, again, it depends which group of patients you are coming, whether you want to increase it every day, whether you want to increase it every 3 days. Because ideally speaking, the literature says that gabapentin you have to increase it every 3 days, and pregabalin you have to increase it every 2 days as per the pharmacokinetics. But here, most of the patients are visiting our hospital every day because they are taking chemotherapy. I have that liberty to see my patients every day, so I can call them every day. So 100 milligrams, or even if you are not calling them, you can just tell them that you take 100 milligrams and every day you try to increase. If you are comfortable with that giddiness and that sleepiness. So you have to, that is how we prescribe this medication, and the maximum dose is 3600, but I had never seen in my life, and even I had never used that high doses in my group of patients. The maximum I used was around 1600, not more than that. So if that is ineffective, if you feel, it's not that pregabalin is more potent than gabapentin, it is as equipotent as gabapentin. Though I have written that if ineffective, you can use pregabalin. That's not, I will say, the 100% right statement. But most of the times what we do, we start gabapentin. If it is ineffective, we go for a pregabalin. So that is how we, I can say, that titrate this group of medications. Now, coming to the Western literature, they say that if you are working on heavy machinery, you inform the patient that you should not work on heavy machinery, that you should not drive. All these also are applicable to us, but I wonder how many of you people discuss this with your patients. But these are very, very important things, and we really need to discuss with our patients. The second thing is the antidepressants, and especially I will say the SNRIs rather than the SSRIs. The SSRIs, they don't have much valuable, I will say, pharmacological effects in neuropathic pain, but the SNRIs, especially, I will say, the duloxetine, especially because we are talking here about the cancer, so that's why I'm going more in favor of duloxetine, because that's a drug which is used and it has been found more effective with respect to the RCTs, as well as I will say the FDA recommendations, that it is a drug of choice for CIP, and no other drug has been very positively recommended for managing CIPN, duloxetine. So the side effects, very important, is the anticholinergic. So there is a lot of dryness of mouth, especially when you are using amitriptyline. Okay, so, and again you have to remember that other group of patients who come to palliative physicians are geriatric group of patients, and you have to be very careful when you are prescribing, because they always have the prostate issues, and amitriptyline causes a urinary retention. Even your morphine causes urinary retention, so you have to be very careful when you are prescribing these drugs, and you have to really take into considerations during the follow-up when they say that, okay, I'm having difficulty in passing the urine. You just can't say, "Are you are old because of the prostate you are having." No. So very careful, you have to be very careful when you are prescribing this medication. So this anticholinergic effect is not an easy effect. Many of the patients will come and say that I'm having a dryness of mouth. All right. I'm not going to that. So carbamazepine we are not talking. So coming to the lidocaine, it's a very, I will say, a favorite drug amongst the anesthesiologists. They will use IV lidocaine for neuropathic pain patients. The most important thing is that either you admit the patients or you don't. Even on a daycare, you can use this. It's not that you have to always admit this group of patients. So 2 milligrams, everyone knows lignocaine is 2 milligrams is the dose which you use. 2 to 4 milligrams per kg body weight is the maximum dose. And if you are adding adrenaline, but we don't use adrenaline in here, so don't think of. So 2 to 4 is the dose. And as Dr. Nandini has highlighted, there are 2 preparations, formulations, and since we are using IV, you just can't use the local infiltration lignocaine because it contains benzalkonium, which is an irritant. So that's why it is not recommended to be used IV. So we have to use something called as Xylocard, which is used in IV. It's an IV preparation which comes with a I can say that benzalkonium. Okay, so you usually give over a period of, I usually give around 20 to 30 minutes this infusion. I used it very rarely. Only 2 patients I used it, IV lignocaine, in my entire practice of palliative medicine. In pain, I have used it when I was practicing pain. Now in palliative medicine, I used it only in 2 patients, but I didn't get any positive results. So they say that if you get so you can continue it by giving around up to 3 milligrams per kg per hour. So I don't know how to manage later on, because you only used it in my 2 patients and I didn't get any effect. The commonest thing is that you have to monitor the side effect. And what's the commonest side effect you can get if there is a toxicity of lignocaine? The first side effect, which the patient will tell you, there is a perioral numbness, and they can tell you that. This has happened to me when I was giving a intercostal nerve block to one of my patients, and I happened to inject into the intercostal vessels, and she developed that. So you imagine you are directly injecting your lignocaine directly into the IV. So you have to be very alert about this side effect. Okay, all right. Coming to the NMDA receptor antagonist, ketamine, another favorite drug. At one stage, I was thinking that I will name my, if I have a daughter, I will name my daughter ketamine. But it's such a favorite, my favorite drug, because I used to use this medication while doing fiber optic intubations. You might be wondering why Dr. Raghu was using this for fiber optic intubations. It is a very good, I will say, and better than a block. You just give 5 milligrams of ketamine, you can directly put your scope into the trachea. Okay, so it blocks the PCP site. Okay, and what, there are many RCTs. Okay, which say that it helps. Okay, but they have the, if you read the paper very well. Okay, the outcome which we actually needed is not much. Actually. We can have a separate talk of ketamine itself for neuropathic pain. I will say that. Then we can talk very, I can say, distinctly about this medication. But bits and pieces, if you see, there are many case reports which say, okay, I am getting a good effect. But there was one systematic review which has come and which has highlighted that it is not of major, I can say, positive effects. If you see the line of no effect and the line of effect, if you see, it is more on the left side. So most of the RCTs which are seen. So it has not given any favorable effects when using this. But many case reports, they say that it gives a good effect. Even I had seen in my practice, if I give this medication, it gives a good effect. But I have not published anything. Don't have a solid data to back up that. But I am just backing up with my experience that it has a good potential. Now it's my job to write an RCT and publish it, saying that yes, it really helps it. Now there are various ways we use ketamine. Okay, there is something called as burst doses of giving the ketamine, or there is something called as a continuous infusion of giving ketamine. So I use the burst doses. Okay, I just give one dose for one day. I call the patient. The next day I repeat the same dose. I call the patient another day. So I give 3 burst doses this group of patients, and very low dose I use. Our 50 kg individual I use around 5 milligrams. Okay, even in 5 milligrams you get hallucinations. Okay, so you have to be very careful when that, and they will say that I am getting that giddiness feeling also. I don't admit the patients. I do it on my office-based practice only, on a daycare basis. I use ketamine, and I had got good results, but I have not published it, so I can't say as an evidence that. But with my experience, I can say that I got good results. Now, the thing is that whether to use it in a long time or not, I have used this medicine for a long-term basis also in an oral formulation. Okay, so you can give this as a oral medications, 15 milligrams to 25 milligrams TDS, and I have used it, and I have used it in almost, I can say, around 5 to 7 patients, where we prepare it ourselves. Okay, our pharmacy doesn't prepare it. Kidwa is lucky that they have their own pharmacist who can do many preparations, but we are unlucky that we don't have that. So what we do is that we make a preparations of 5 milligram per ml formula. We make it. Okay, but the thing is that have you ever tasted ketamine? It is bitter. I have tasted ketamine myself. It is very bitter. So they won't like the taste. So we either put it in a orange juice, or we put in a high 25% dextrose. So we prepare in that so that it tastes well and it is palatable. And we give it for 7 days with these preparations, because the shelf life when you prepare it is for 7 days only. Okay, it is not more than that. So we call them back after 7 days. So I used it for 3 weeks in my patients, and I had got some good results. But again, I am saying that I have not published it, so I can't back it up with the evidence, but other than my experience. So it's a good drug, but if you see the recent guidelines, there is an inconclusive evidence. So it is our job to make it a conclusive evidence now. Okay, so subcutaneous infusions, I have no experience. Maybe Dr. Nandini, you might have used subcutaneous infusions. I have not used a subcutaneous infusion of ketamine, though I have used opioids, but ketamine I haven't used it. So I have no experience regarding that, other than just talking my slide. All right. There are many other therapies where we can use. One thing I would like to highlight about lignocaine is that especially in post-herpetic neuralgias, because in cancer patients they are immunocompromised, and you do see almost 5% of the patients do have a post-herpetic neuralgia. If they have allodynia, I will tell you that use this medication, because it prevents allodynia, because they can wear at least their clothes. Okay, so such severe is allodynia. So other than the effect, I use it as a barrier in my group of patients about this lignocaine. So the principles of drug selection, again, more important thing is that you have to look for the drug efficacy, you have to look for the side effects, and as I said, you have to personalize the therapies based on the patient who is coming to you, his economic things, his other comorbidities, many other things you have to take into considerations when you are prescribing medications. Recognize when to combine the medications. Okay, so there are very partial responders. In partial responders, we try to combine. Nowadays, you see there are many medications, GABA NT, and all those medications which are coming into the market. The biggest problem with combination drugs is that you can't titrate, and even if you want to give them as a BD dose or a TDS dose, for example, if I want to give gabapentin TDS, yeah, and if it is a GABA NT, I can't give nortriptyline TDS. So I have that limited choice. So it is very, very important. So I give GABA BD and then GABA NTHS. So that's how you should know how to play with your medications which are available to you. All right. And switching, if consider no benefit at the maximum tolerated dose. As we do switch for our opioids, the same switch applies to other group of medications. We have to adapt it for the special populations. This is very, very important because you might be seeing most of the patients are having kidney disease or a renal failure or a hepatic failure. And if you see, especially the gabapentin, because it is mostly dependent on the renal clearances, it is very, very important. You have to know, based on the create clearance, you have to adjust your doses. Okay, same happens to the pregabalin. And if you see this, I have highlighted. Okay, and if the patient, whether he is having just, you are calculating the create clearance, and if he is not into full, I can say the KID, I forgot that criteria, Rifles criteria, and there is another criteria, kidney. So based on that, if the patient falls into less than 15 ml per liter, ml per minute of the GFR, is into complete renal failure and is on a hemodialysis, again post hemodialysis, how to give these medications, I have highlighted this. So these slides will be shared with you, so don't worry. All right, so you have to be very careful at what time you are giving this medication. So if the renal clearance is normal, the maximum doses you can give, but if the renal clearance is less than 60, so that is the point we take it, and up to 30 ml per minute, you cut down. The maximum dose is 1400. So half of the maximum targeted dose you give, and if it is less than 15, you can still give. It is not that you can't give, and it is less than almost up to 300 milligrams once daily, you can give it rather than giving it BD. So that is what. And due to lack of time, I won't be going into all these things. But if you see this, most of them are favoring, and if you see, most of the things are all radiculopathy, peripheral neuropathy, post-herpetic neuropathy, diabetic neuropathy. Rarely you will see the cancer things, except for one, this 1995 study of chemotherapy in this peripheral neuropathy over here. So you see that. So, thank you. Over here, okay. So it's favorable results. So this is a line of no effect. So anything which is on this side is always a favorable things. You see, almost all of them are having a favorable effects, and if you see, most of them are all non-cancer pain, non-cancer neuropathic pain, except for the chemotherapy-induced pain. So I think the onus lies on us now that we should come with some solid data. So takeaway points: it's a neuropathic cancer pain arises from the nerve injury by the tumor or by the treatments, and it requires adjuvants beyond opioids. This is very, very important. First line of drugs are gabapentin, pregabalin, amitriptyline, and duloxetine. So these are the only 4 drugs where you can play with. Then you can, ketamine can come into play if it becomes, I can say, an intractable thing. Okay. Then adjust the doses in renal or hepatic impairment, especially the gabapentinoids. Monitor the side effects, very, very important. Okay. Evidence specific to neuropathic cancer pain is very, very limited. Newer agents are still under investigations, and multidisciplinary management. It is always multidisciplinary. It is not only me, it is we. That is what you have to remember when you are managing pain as well as palliative care patients. Okay. So thank you very much.